Hello, my name is Dr. Sehan Akkad, and I'm one of the clinical fellows at Northampton General Hospital. My colleague Eleanor Atkinson, who is also a clinical fellow here, has helped me to put together this presentation. Today we are going to talk to you about bronchoscopy. I'm now going to talk to you about the definition of bronchoscopy. Bronchoscopy is an endoscopic technique of visualizing the inside of the airways for diagnostic and therapeutic purposes. There are two main types of bronchoscope, rigid and flexible. Rigid bronchoscopy uses a straight metal tube with a beveled distal tip inserted into the trachea and is less frequently used in critical care than flexible bronchoscopy. It does have its advantages, however, in clinical situations such as massive hemoptysis, removal of a large foreign object, or stent procedures. Flexible bronchoscopy is the most common type of bronchoscopy in critical care. The flexible bronchoscope has a mechanism to flex or extend its distal end, which allows access to otherwise inaccessible areas. And there are some variants of this traditional flexible bronchoscopy, such as endobronchial ultrasound, shortened to EBUS, which is used to facilitate needle aspiration of enlarged lymph nodes. The bronchoscope is usually inserted through the nose or the mouth. It can also be inserted through an endotracheal tube or a tracheostomy, and this is the case in the majority of patients who are going to be on the intensive care unit. It can usually be undertaken with either topical anesthesia, usually lidocaine as a spray as you go, and this is normally done in theatres, or with sedation. I'm now going to talk to you about the indications of flexible bronchoscopy. Flexible bronchoscopy is used in critical care and anesthesia for a multitude of different indications, and here you can see there is a table which lists these. The clinical indications are based on a triad of inspection, sampling, and therapy. I'm going to talk to you first about aspiration. Aspiration of gastric contents is often underdiagnosed in critical care patients, and it accounts for significant pulmonary dysfunction. Usually, the aspirated material is liquid and disperses rapidly, and so routine bronchoscopy with lavage is unlikely to prove useful. In the event that the aspirate is predominantly particulate in nature with clear radiographic evidence of lobar collapse or major atelectasis, a therapeutic bronchoscopy may prove useful. If a substantial volume of gastric content is aspirated, prompt bronchoscopy can be used to remove aspirated gastric fluid and solid material from the central airways, reducing the inflammatory reaction, preventing atelectasis, and reducing the risk of infection. Aspiration of gastric contents with a pH of less than 2.5 was traditionally thought to be necessary for the development of aspiration pneumonitis. However, aspiration of particulate food, even with a pH greater than this, can cause significant pulmonary damage, and hence bronchoscopy can be used for both sampling and therapeutic removal of this gastric contents. In many units, bronchoscopy can be used in order to collect microbiological samples for testing in terms of infection. Almost 20% of patients on the critical care unit who are on a ventilator will develop a ventilator-associated pneumonia, shortened to VAP. Bronchoalveolar lavage can be used as an alternative to bronchoscopy in this circumstance to collect some samples for microbiological analysis, and as it's less invasive, should be used first before bronchoscopy is considered. Flexible bronchoscopy can be used in patients with lobar and complete lung collapses in mechanically ventilated patients who fail to respond to treatments such as physiotherapy or recruitment maneuvers. Local suction combined with installation of saline or mucolytics can be used to treat airway plugging with mucus, blood, or secretion. Flexible bronchoscopy can also be used in patients who are difficult to intubate, such as grade 4 intubations, which allows visualization of the airway, including the epiglottis and vocal cords, without the use of laryngoscopy. This flexible bronchoscopy can also be used in airway assessment for acute inhalational injury, burns, trauma, and can also be used as an aid to direct visualization during tracheostomy procedures. Bronchoscopy can also be used to look at and remove foreign bodies and can be used in aiding to find strictures and stenosis and to help with stenting of this area. It can also be used in hemoptysis or hemorrhage to locate the source of the bleeding and to also be able to stop the bleeding in certain circumstances. It is important to consider local resources such as rigid bronchoscopy or interventional radiology as first line in the cases of hemoptysis or hemorrhage. Surgical treatment may also be required. Bronchoscopy is a relatively safe procedure with a less than 2% rate of complication. However, there are some absolute and relative contraindications which I will discuss now. If there is an extremely large upper airway bleed and you are unable to visualize the structures during bronchoscopy, then this should be abandoned and other alternative methods for stopping the hemorrhage must be sought, such as rigid bronchoscopy, interventional radiology, or surgery. If the patient is unstable with an untreatable, life-threatening arrhythmia, then bronchoscopy should be abandoned and the patient should be stabilized before proceeding. If you are unable to adequately oxygenate the patient during the procedure, then this should also be abandoned until the patient is adequately oxygenated, and then the procedure can be reattempted. The same can be said about a patient who's in acute respiratory failure with hypercapnia. This should first be corrected, if possible, using a ventilator, and then once the PO2 and the PCO2 has been normalized, then the procedure can be reattempted. In the case of a high-grade tracheal obstruction, it may be impossible to insert the bronchoscope without risk of perforation of the trachea, and in this cases this should not be done and bronchoscopy should not be attempted. As well as if a simpler technique may be used, such as bronchoalveolar lavage, then non-invasive techniques should be considered first before bronchoscopy, as these can provide almost the same samples without the risks associated with bronchoscopy. Now I'm going to talk to you about the anatomy of the trachea. So the trachea is the windpipe and is made up of 16 to 20 C-shaped cartilages. The trachealis muscle composes the back wall of the trachea, and the trachea terminates at T4 and T5, where it divides into the left and right main bronchus. And now briefly about the anatomy of the bronchial tree. So at the top of the image you can see the thyroid cartilage, and below this cartilage you can see the cricoid cartilage. The cricoid cartilage is the only complete ring of cartilage in the trachea, and between the thyroid and the cricoid there is the cricothyroid membrane, and this is very important for emergency access in front of neck access in a can't oxygenate, can't ventilate patient. Below this you can see the trachea with its rings of cartilage, and then the trachea then splits into the right and the left main bronchus. And as you can see here, there is an image which shows all of the different bronchioles which are present. The bronchopulmonary segments vary between the lobes, and here is a useful mnemonic for learning the lobar anatomy. And for the right lung, there is a palm, and for the left lung, it's apal. And in the image you can see the names of the bronchioles. Performing bronchoscopy has many physiological changes. It's very important to know what these changes are and how they can affect your patient. Insertion of the bronchoscope causes a partial obstruction of the airway, leading to an increase in the airway resistance, peak inspiratory pressure, reduces the tidal volume and increases the PEEP. This is further aggravated with a decreasing endotracheal tube size. Assuming that you have a laminar flow by the Hagen-Purcell equation, the resistance to airflow is inversely proportional to the fourth power of the radius of the tube. Therefore, obstruction in the airway causes a marked increase in airway resistance. Intrinsic PEEP also increases due to impedance to the expiratory flow and insufficient time to complete expiration. A PEEP of up to 35 centimeters of water has been reported with a size 7 tube, but this usually remains below 20 with a size 8 tube. There are also changes in the lung compliance, both in the dynamic and static compliance, primarily because of alveolar collapse, but suctioning and instillation of normal saline during bronchoalveolar lavage can wash out the surfactant and affect the compliance as well. The most common abnormality is a transient hypoxemia, mainly due to alveolar collapse, but also there is a depletion of the intraalveolar oxygen due to the frequent suctioning and flooding of the alveoli during bronchoalveolar lavage. There is also a hypercapnia, which is a result of the hyperventilation caused by the airway obstruction. There is also an increase in the pulmonary vascular resistance, and this can cause significant hemodynamic changes in your patient. Changes in intrathoracic pressure may affect venous return afterload, which can reduce the cardiac output. However, there can also be an increase in the sympathetic stimulation during the procedure, which can actually increase the cardiac output as well. Finally, there can also be an increase in the intracranial pressure during the procedure. Now we're going to look at some images of the views that you may see during bronchoscopy. To the left side of this image, you can see the entrance to the laryngeal inlet. At the bottom of the left side image, you can see the epiglottis cartilage, and at the top of that image, you can see the paired arytenoid cartilages. You are also able to see the pearly white of the vocal cords. If you go through the vocal cords using your bronchoscope, you can then see the image on the right-hand side of this picture, which is an image of the carina. Here you can see the right and the left main bronchus. You are then able to go down either of these bronchi to look at the bronchioles and either take a sample or visualize or have a therapeutic effect on the area of the lung that you need to go to. So now I'm going to show you a picture of the trolley that we have at Northampton General Hospital, which is used for bronchoscopy. So as you can see, on the top of the trolley we have the screen which is used with the disposable ambiscopes, and we have the ambiscopes which are found on either side of the trolley, and inside the trolley there is a lot of equipment that will be used during the bronchoscopy. As you can see here, this is more of the setup. Okay, normally the ODP will be able to help you with the setup, but as you can see we have the angle piece, and here the angle piece will allow you to oxygenate the patient during the procedure, and also you can have a look at the xylocaine which we normally spray onto the cords to anaesthetize the vocal cords and also to reduce the amount of bleeding. And now I'm going to talk to you about the scope choice. In our hospital, we use the ambiscope, and we have two types of scopes which we can use. So as you can see on the side, there's a green scope, which is used for most standard procedures. And then we also have the orange scope, which is a larger scope, which can be used if there is a lot of debris in the trachea that needs to be removed. The next thing we're going to show you is a video about our ambiscope and the trolleys that we use here in Northampton General.
And today I'm going to show you and talk to you about the bronchoscope. So in our hospital, bronchoscopes are once only use, and we use the brand Ambiscope, and they're found on our bronchoscopy and tracheostomy trolley, which you can see here. Okay, on the top of our trolley we have the Ambu screen. Okay, normally this is plugged in to the wall, and ideally once you remove the trolley, unplug this first, and then when you brought it to the bedside you can plug it in again. You can switch it on with this button at the top here. Now we're going to talk to you about the ambiscopes. So you can see that we have the ambiscopes here on the side. We have two sizes here, a green and an orange. Okay, normally we use the green one for most standard uses. These are disposable, and normally they're used once for one patient. However, they can be kept for 24 hours if required. Okay, so these scopes are plug and play scopes. Okay, so as you can see, this is one of the flexible scopes that we've used in the past. Okay, it's an ambiscope. It has a wire here which connects to the ambu screen, and it's color coded. So there's a blue arrow here, and that goes into the side of the port onto the blue side, with the blue arrow pointing to the other blue arrow. Once this is connected and the screen is turned on, then you should be able to see a picture, and the light source will come through the screen there. Okay. On the actual scope, you can see that there's a lever here. This lever is very important because it allows you to move the end of the flexible bronchoscope, as you can see here, during your bronchoscopy. On the side, you have a suction port, and this attaches to the suction. And you have a button here which is pressed in order to activate the suction. At the top here, you've got a port which can be used to instill saline if required, depending on what you're doing with the procedure. In the rest of the trolley, you will see some more equipment that we need, such as syringes, kind of saline, areas where you can put the sample in, such as these yellow tubes here. And these can be connected onto the ambiscope through the suction port to be able to collect the specimen. Thank you very much for your time.
This is an image of the reusable scope that we used to use in Northampton General Hospital for bronchoscopy. This is the Stores scope. In the next slide, we will talk more about the different components of the scope and how it's used.
So now I'm going to talk to you about the reusable bronchoscope. So in our trust, we used to use this kind of a bronchoscope, which is called the Stores bronchoscope. And as you can see, it's black in colour with a silver handle. and this is our reusable bronchoscope. So it's very similar to the ambiscope that we discussed in the previous video. So the first thing you need to realise is that it must be connected. So here we've got a connection cord, and this normally connects into the monitor which is for this store's bronchoscope. Here, as you can see, there's a lever, and this lever is used to control the distal tip here, as you can see. And the rest of this is called the shaft. On the handle, there's quite a few different ports, which I'm going to talk to you about now. Okay. So the first port here is called the suction valve, and normally it has a connection here, which I don't have. And here you've got the suction cylinder. On the side here, as you can see, there is a connection for the leak tester. And as you can see, the leak tester is over here, and this is what you would use to do that. Moving on to the top of the handle, you can see that there's a few buttons here. And these buttons are important for when you are actually operating the bronchoscope. So at the top here, you have a button which is used to start and stop recording videos. And in the middle, you've got a button for the white balance. Before you start using the bronchoscope, it's very important that you take a piece of gauze to the distal tip of the bronchoscope and that you press this button to ensure that the camera gives you true white colours. Lastly, as you can see here, there's a button which is used for taking still images as well. Finally, once you finish using this bronchoscope, you must be very careful with it, because even though it's a very robust bronchoscope, it is fragile and one needs to take care when using it. Once you've finished using it, you cannot dispose of this as it's reusable, so you need to send it for cleaning and sterilisation, and that will depend on your trust. That's what I'm going to talk to you about today. Thank you very much for your time.
This is an image of the specimen collection setup. As you can see, you have the ambiscope, which is connected to the specimen pot, which is connected through via the suction port. And here, this allows a specimen to be taken during bronchoscopy. Now I'm going to talk about the bronchoscope and how it works. Fibre optic scopes are very fragile and vulnerable to damage. This is why many places are moving away from the reusable scopes to using disposable one-time only use scopes. Many different companies manufacture flexible bronchoscopes. However, the overall principle and design is very similar. A typical flexible bronchoscope contains a handle which contains an eyepiece, a control lever for enabling bending of the flexible bronchoscope tip, a suction button, and a port to access the suction channel. The insertion cord contains the light and image bundles, suction channel, and the tip bending control wires. These components are held together by a stainless steel mesh and wrapped in a water impermeable plastic coating. You also need a light source in order to distinguish objects during bronchoscopy, and it is essential for adequate illumination. There's many different light sources available, although a xenon lamp for white light with switchable filters is used in the majority of scopes. Bronchoscopes work with refraction. Once you reach an angle which is greater than the critical angle, you get a physical phenomenon called total internal reflection, which is what the bronchoscope uses in order to relay its images. These optical fibers use total internal reflection to transmit light along them. Bowden cables connected to the lever on the handle piece allows the tip to be orientated. There is 5,000 to 40,000 fibers which are aligned in a coherent fashion so that they transmit the image in the same relative location on both ends of the bundle to represent the true nature of the object being viewed. Alongside the coherent bundles, there's also non-coherent bundles which are used for illumination. I'm now going to talk to you about preparation of the equipment. So before you start the procedure, ensure that you have an appropriate bronchoscope with which you are familiar with before starting the procedure. And also ensure that you have an assistant available who can help you with the procedure. In our unit, we have some ODPs who are trained to help us. However, in other places, this may be the bedside nurse who's looking after the patient. You may also require some xylocaine to anesthetize the vocal cords. Ensure that all of the equipment is checked prior to the procedure and laid out in an easy to use manner. Ensure that the scope is properly focused, as this will help you to get the best images possible during the procedure. And make sure that you have equipment for specimen collection if needed, and in the majority of cases you will require this. And make sure that you set up your screen so that it is easily viewed by the operator. And ensure that you have suction available to clear any debris or blood or vomitus that may be in the airway. I'm now going to talk to you about preparation of your patient prior to bronchoscopy. Think about whether your patient needs an anti-silagogue or aspiration prophylaxis. This is very dependent on your patient's circumstance, but needs to be considered. Ensure that the patient is adequately sedated and, if required, paralyzed. If the patient is able to, they should be consented prior to the procedure. However, if they lack capacity, a consent form 4 must be completed prior to the procedure. Position the patient appropriately to ensure the best view for you and ensure that the bed height is good for you as an operator. Ensure that the patient is put on appropriate ventilator settings before you start, and pre-oxygenate the patient to ensure that the lungs are denitrogenated before starting the procedure. And of course, ensure that the patient has full monitoring on. This is usually the case for most ventilated patients in the intensive care, but if not, make sure that you do that. Now I'm going to talk to you about troubleshooting. So during the procedure, if you have any issues, think about the following things. So, why can't I see? Are there any secretions or blood in the airway? If so, you can gently touch the mucosa to clear the camera, or you can use the suction to try and remove these secretions or blood. Fogging. So if the camera tip has fogged up, then what you can do is clean the tip with an alcohol wipe before the procedure, or you may need to remove the bronchoscope and do this again. And did you ensure that the bronchoscope was properly focused before you started the procedure? Why can't I get where I need to be? So if you're doing the flexible bronchoscopy through the nasal passage, you may want to consider using the other nostril or a different route such as the oral route. You may also need to reposition your patient and do some maneuvers such as a jaw thrust or laryngoscopy, but this depends on which route you're going to use in order to do the bronchoscopy. And sometimes paralyzing the vocal cords adequately can help you to get past this and into the trachea. If in doubt, get senior help. This is a very important thing to remember. So now I'm going to talk to you about aftercare and cleaning. So ensure that the patient's vital signs have normalised and check that the patient is reconnected to the ventilator and appropriate settings are chosen. Some of the scopes are once only use, and these can be disposed of after use in appropriate chemical waste bins. The reusable scopes need to be sent for appropriate cleaning and re-sterilisation, and this needs to be discussed with your assistant who can help with this in most circumstances. Usually, a 2% glutaldehyde solution is used, and the scopes are immersed in there for 10 to 20 minutes for cleaning, and then for sterilisation, ethylene oxide can be used for this, and this usually takes about 5 hours, but can differ depending on your local hospital and the cleaning and sterilisation guidelines for your reusable scopes. Thank you very much for your time. Here you can see the references which I have used to put together this presentation. Thank you very much.